Management here at McGill. So along with Professor Jinxia Liu, who is the director of the Bray Center, and Professor Subhashis Ghoshal, who is the director of TICED, we'd like to welcome everyone watching to today's seminar, which is an event co-hosted by Brace and TICED. So shortly after this novel virus SARS-CoV-2 was first officially detected in Canada in late January 2020, many Canadian researchers started collecting and analyzing municipal wastewater samples in various regions around our country in hopes that this surveillance can be a reliable predictor of future COVID-19 outbreaks in urban settings. This surveillance effort is a collaboration between many stakeholders, as you'll hear today, including researchers, laboratories, wastewater utilities, and public health authorities. And today we're very pleased to have three speakers that are part of this collaborative effort: Professor Dominic Frigon, Professor Sarah Dorner, and Professor Robert Delatolla, who will present their research findings of the COVID-19 sampling and testing campaign in Ottawa, Hamilton, and Montreal wastewaters. So just a quick housekeeping note before we start. After the presentations, we will have some time to answer questions from the viewers. So please feel free to enter them into the chat throughout the talks. If you can, it would be helpful if you can note to which speaker the question is being addressed to. So with that, I'd like to introduce our first speaker, Professor Dominic Frigon from the Department of Civil Engineering at McGill. His research aims at constructing mathematical models describing the dynamics and activity of microbial populations present in wastewater resource recovery systems. These models are then validated in laboratory scale and full-scale experiments using molecular, DNA-based and RNA-based microbiology and genomic techniques. Professor Frigon.
Thank you. So what I'm going to do as an introduction here is I'm going to give you a bit of an overview of what we're talking about when we talk about monitoring SARS-CoV-2 in wastewater, and give you an overview of a large project that we have here in Quebec. It's a $1.7 million project over the next 6 months or so that will actually study the deployment of this in of this project in, or the monitoring approach in Quebec. So this is me, and I'm the coordinator of this this project. So the project is Centro COVID because it's supported or it's been coordinated through the Centro Research Center. And I'm just putting you a brief list of some of the PIs involved and a lot of the regional public health authorities, just to give you the size of the project we're talking about. And in fact, if we list all the municipalities and everybody involved, it's a project that has probably about 100 participants in some way, shape, or form at this point. So what is monitoring of wastewater of COVID through wastewater? Essentially, what we typically do to monitor COVID, right? We have a population living in cities or in different settings. Some may carry the virus, SARS-CoV-2. And it's typically, of course, intact in individuals. That's how it's dispersed. And we take samples from the nose, and we do what we know. Probably we've been all exposed over the last year through that. We do a PCR test from the RNA to detect the presence of the virus. In wastewater, we can actually do the same. So as people are infected, there's sub-infections that do happen in the intestine, and you have a discharge through the wastewater. So you can take samples at the end of the network. So of course, at that point, it's very much diluted. So we need to reconcentrate the virus, but we then do the detection and the quantification of the viral load using the same qPCR test as you would have in for individuals. The SARS-CoV-2, the virus at that point, is typically somewhat inactivated. From wastewater, I don't know of a lot of studies that were able to isolate live viruses from wastewater per se, and already from fecal samples, it's already hard to pull out samples. So the virus at that point is not intact anymore, but we're probably collecting the RNA within the proteins that we call the nucleocapsid. We can do the samples at the end of the network, but we can also go within the network and analyze either within a neighborhood or even at the end or the exit of an institution like a hospital, a CHSLD, or a prison, and that gives us different level of spatial resolutions. The matrix that we're analyzing, the wastewater, is varying quite a bit. So in addition to the SARS-CoV-2, the virus, we're analyzing also different viruses that we either that are present in the wastewater as fecal indicator, or also we spike as external controls so that we can test the recovery and make sure that everything works perfectly from day to day. If I just quickly go back historically, over 1 year now, the first data came out of the Netherlands, and what we do see here, that's the study that they published. They have the number of cases in about 6 cities that they've monitored over a certain period of time in the first wave, and they were trying to determine what would be the detection limit. So these were cumulative cases per 100,000 people, and the gene copies selected. And this study suggested that there was a 1 per 100,000 people detection limit. Now we're claiming more, probably around maybe 10 times less. So 1 to 10 cases per 100 people is probably detectable in the sample, at least for a large municipality. In terms of detecting the viral load dynamics and relating this to the number of cases, what we found, or what was found in Connecticut at Yale, so these are the samples or the data, and you can see how noisy they are. But if you actually take an average, a moving average of these data, you find that the viral loads typically would rise about 2 to 7 days before the clinical cases. So there's a bit of early detection that is possible there as well by a few days, which could be useful for public health as well. Same thing here in Paris, similar there, and we see the viral loads in the wastewater at the end of the summer. So this is the beginning of the second wave going back up faster than the clinical cases. So suggesting again that there's a bit of a precursor data there. So, and I apologize, I'm switching between French and English. I did not have the time to translate all the slides, and since we're dealing with public health authorities in Quebec, all of this is happening in French. Essentially, when we talked with public health, and we started from the ground up with the people that were actually going to use these data, it's not the ministry, but really each regional public health authorities. They told us, well, this early detection is important for us, and we should try to optimize this. It's good that we could potentially detect asymptomatic cases, but really, if we want to be able to do something with that information, we need to be able to locate that information more precisely on the territory. In Montreal, for example, taking one sample for 2 million people, not very useful. You need to go at the neighborhood level to be useful. You know? So really what we are trying to do is detecting, for the most part, do we have an increase? And where is this increase, for example, in Montreal, so that public health could actually act upon this information. Now, the other thing that we can potentially do is when we have control strategies in place, we can potentially evaluate relatively quickly how fast they're getting, or how effective they are, right? So potentially detecting not only the increase, but also is there a decrease? But there's a little bit of a question there, because the people that are infected, even after they recover, they can shed the virus for a very long time. So we actually have, when we have very high level of infections, there's some regions that are reporting that the decrease is not necessarily very fast on the way down at that point. But so it's still areas of research right now. Now, how do we cover the territory, right? And that was in Quebec, that's one of the main questions that we have. So what we see here, all these points on this map are the wastewater treatment plants. So there's just about a bit less than 1,000. But they cover, of course, different level of people, and those that are in rural areas, they may be hard to sample, and there's not a lot of resources. So at first we were thinking, maybe we want to cover all that territory at the beginning, all at once every day. But you quickly realize that it's not feasible. So then we developed kind of an approach to try to adapt our strategy of deployment with different conditions. So if we look at the design that we approach, so if we consider these general considerations, we know that the limit of detection is probably around 1 to 10 cases per 100 people. We have this early detection, 2 to 7 days, right? And when transmission is high, we want to maintain that. We need to maintain a relatively low cost, and sampling everything every day may not be good enough in that sense, but we still want to try to cover the entire territory. So what we've decided to try is to have in dense urban areas, to have neighborhoods defined around 100,000 people, and have daily sampling, because we're expecting very rapid transmission, and try to develop the capacity to adapt our sampling. So we've introduced the use of passive sampler. So instead of having a machine taking the sample, which we know exactly how it works, we can maybe have devices that absorb particles over a certain period of time, which we would actually test to see if we can increase our capacity to deploy at different regions in Montreal, for example. And when we go to rural areas, we're expecting, well, now we have a large area that is hard to sample because there's low resources, both human and financial, but we're also expecting slower transmission. And probably a lot of the area is going to be negative most of the time. So what we're thinking of doing there, and then we're implementing in this research project, is to sample every 2 to 3, or so sampling 2 to 3 times a week. Pooling samples to have about 50,000 people in one analysis. So we take municipalities and pool these samples. But then if we find a sample that is a pooled sample that is positive, we can re-explode it and determine exactly what municipality have cases, so public health can actually act upon this very quickly. So overall, this large project have objective to test these premises and validate for public health the value addition of COVID, of the sewer monitoring, and understanding if we want to cover the entire territory, what are the limiting steps, and suggest strategies to do that, which is slightly different than what Ontario decided to do, and maybe Rob will tell us a little bit about that. And then, of course, we have other side projects. Ethics and governance is very important for the project in Quebec. So we have actually a team that is thinking about these things, and we are also developing on the side other approaches like the modeling of faith and transports to understand better the signal, detection of new variants through sequencing, and things like that. So we're covering in this pilot project 5 regions. So the cities of Montreal and Laval and Quebec City, and two regions, the Mauricie Centre du Québec and Bas-Saint-Lau, which are more low density regions. Just to give you an example of the concept in Montreal, this is not the details, but really the concept. So in Montreal, we have the two collectors, the north and the south collectors. Sarah has been sampling, the group of Sarah has been sampling at the end of these two collectors since the beginning of the pandemic, and hopefully we're going to see some of these results today. But the idea is to also subdivide then the city into neighborhoods that we're going to follow on a daily basis. So lots of sample to process, and our groups are now sweating in the lab implementing this. In terms of the problems that we see in these the rural areas, we see a very large area here, like so the distance is 300 kilometers, so several hours of driving just to go collecting. And so you see the difficulty of sampling this every day. And most of these treatment plants, so in green here are areas where we do have sewer systems and treatment plants. Most of these areas have very low personnel, so they don't even sample their treatment plant or their sewer every day. They actually sample it maybe once a month, right? So going to a weekly or bi-weekly sample is already quite a bit of work for them. But at the same time, probably most of these areas will be negative at any one time. So that's how we decided to actually try to make this compromise in this approach. If we look at the cost in the end, and I will finish here. Back in October, we were to monitor Montreal. We were trying to do about 8,000 tests, costing just below $50 each. So 8,000 tests a day, and we're not testing the entire population. We're just testing those that seem to have symptoms. So overall, that comes back to about 20 cents per these 2 million people that we're trying to monitor, yet monitoring them only partially. By this approach, where we cover with one sample about 100,000 people, the sample itself costs a lot more, the sampling, but we're calculating that covering the entire island this way is about 1% of the cost of the individual testing. So what we're saying is in terms of the value addition, we were thinking that it's a lot more than 1% that we're bringing as additional value. It's obviously complementary, but it's probably the value is probably a lot more than 1% of the value of the clinical testing alone. So I will stop here, and hopefully that gives you a good overview, and my colleagues will actually take the relay maybe and present some of the interesting results that we obtained.
Thank you so much, Professor Frigon, for this great introduction to the issue at hand. So our second speaker is Professor Sarah Dorner from the Department of Civil, Geological and Mining Engineering at Polytechnique Montréal. She holds the Canada Research Chair in Microbial Contaminant Dynamics in Source Waters. Professor Dorner's research is focused on developing computer models to understand the fundamental processes governing the fate and transport of microbial contaminants in water under changing environmental conditions. So I'd like to now welcome Professor Dorner.
All right, thank you. So I first would like to acknowledge all of my co-authors of this work. Dominic had mentioned that there are approximately 100 people involved in these projects. So although my name is on the title slide, as I go along, I'm trying to acknowledge some of the people and the unique contributions that various people have made to this. It's been a really exciting time to be working with an international community, looking at these problems, and also having amazing support very locally from people, for example, the city of Montreal. So today, one of the things I wanted to talk about was like, how did I get involved in this, especially in the context of a pandemic? and how, because we hadn't been doing virus analyses ourselves, how did we ramp up to be able to do this? And so we had very specific, unique conditions that allowed us to do this. We're an engineering group, we're not microbiologists, but we really need the interdisciplinary collaboration to get these projects off the ground. I'll also talk about the results from Montreal, but also I thought it would also be useful to talk about it in a broader context of viruses in the environment, because a lot of people think there's viruses in the water. What is the risk, for example, even to drinking water? And there isn't for SARS-CoV-2, there isn't a risk to drinking water, but it's something that needs to be addressed to reassure the general public. And also, where do we go from here with our monitoring? So one of the things that I thought would be kind of fun, but also explaining what we were up against here in Montreal. So I thought I'd go into my archives, because I've been thinking about infectious diseases and emerging infectious diseases for quite some time. My PhD thesis was bookended by, on one end, the Walkerton tragedy with E. coli 157H7. And towards the end of my PhD, we had the first SARS that arrived in Toronto. So here's an actual slide from one of my presentations from back in 2005 about emerging diseases, and reminding us that even though there's a lot of focus on this particular coronavirus, it's not the first and it won't be the last. And so a lot of the work that we're doing now, we're kind of building the plane as we're flying it, is how a lot of people have been describing it. But we hope that in the future, what's being done, because there's a tremendous amount of research going on about the coronavirus right now, that these kinds of systems will also be in place for the future, because this could happen again. So this is a slide from back in the day, still worried about terrorists, no Canadians. And now I would update that to Montrealers from last summer, and reminding us also of the stigmatization that comes with infectious diseases. And certainly here we were trying to do research on this, but also deeply affected by the pandemic itself. So at the beginning of 2020, there were so many unknowns about SARS-CoV-2. And for example, many of us, and especially in places like Montreal, we live in multi-residential housing. And here we are with, like, for me personally, there were 12 people in an apartment in a building with 6 apartments that had SARS-CoV, that had COVID back in the day. And so we were at one time trying to get research going to help out and help our community. But on the other hand, we also had to think about, okay, how do I keep my family safe? Because we actually it was present, it was in our midst. And so a reminder, like, although this virus is not transmitted through water, the first one, there was thoughts that it could be carried through fecal droplets, now also called aerosols, and that there was a miscommunication between aerosols and droplets. That's getting sorted out. But in March, the picture on the right here is actually what I did, because how do I protect my family? I was just like, okay, the ventilation for our sewer system is not great. I just taped it up. It's sort of like an engineering fix for what was going on. So we were on one hand trying to get research going, but on the other hand, having to protect ourselves in our labs, but also in our own homes. So this is kind of getting to how I ended up even looking at viruses in wastewater. Very early on, I had first put together a proposal with a group of Japanese researchers to look at viruses coming from wastewater in view of the 2020 Olympics. It wasn't funded, and the Olympics didn't happen. But that's sort of how I got started in this, was through an initial collaboration with researchers in Tokyo. So what we did, though, we did get the research off the ground, and it was to look at viruses in rivers. So these are some of our results from 2 years BC, before coronavirus, looking at viruses in a river near Montreal. And so we weren't at the time doing any of these methods ourselves. We're engineers. We wanted to have good results. So we set up a collaboration with Lily Pang in Alberta. And what we looked at was really how these viruses, during events like snowmelt events, we were very interested in snowmelt particularly, because that's a time where we have a lot of combined sewer overflows, a lot of sewage bypasses into our rivers. And so we wanted to have a better understanding of these viruses. So this last year, 2020, February 2020, we were all set up. This is actually one of my dreams, was to use a ice fishing hut, because it's like the perfect situation to set up a mesocosm study in the winter, because you can be a little bit warm and comfortable. And a mesocosm is, we wanted to take sewage and understand how viruses were inactivated under just prior to snowmelt conditions, because that would give us an indication of how viruses are transported in rivers upstream of drinking water intakes and such. But that didn't happen. So our virus study didn't happen because of a virus. But we had a network in place, collaborations with municipal partners, with groups like Lily Pang in Alberta, who had set up methods to study viruses in wastewater. Also with Gertjan Medema, who was whose main group was the first group to come up with with these methods to study the coronavirus in wastewater in the Netherlands. So we had this network in place, and what we had been planning and what we had funding to do to look at viruses in raw wastewater was all set up. So it was very easy for us to then switch our focus to look at viruses, instead of looking downstream in the rivers to look at the effects on rivers, and not knowing exactly if there was an effect potentially, if it was an active virus. At first we didn't know, and so it was very slow for us to get into our labs. But we had everything in place to be able to move quickly once we were able to move in. And fortunately, there's no evidence at this point in time that that the virus is transmitted through wastewater systems. So as we were getting ramped up, we got a lot of help from a lot of people. So the really nice thing about what's been going on with monitoring the coronavirus in wastewater is that there are a lot of people working on this problem simultaneously. And so I'd say it's the fastest ramping up of methods and ways of doing things that I've ever seen in my career, because so many people were working on it parallel. Some people would find that something worked better, and so the information got shared very rapidly. So we were part of this first study with the Canadian Water Network to look at different methods. Different labs participated in this interlaboratory study, and it allowed us to test our own methods, because this is us doing it for ourselves for the first time. So we were able to participate with a lot of help from Lily Pang's group and Dominic Frigon's group. And so we had kind of separated out what we would do. And so we were looking first at the aqueous phase, and Dominic's group was looking at more the solids phase. And so we got a lot of help. And there were some interesting observations from that first study. And one of the things was that different protocols can produce similar results. And so there's a lot more confidence in these methods. It also meant that our lab, actually had really good results from that first study. And it gave us the confidence to be able to apply these methods, because what we had been doing with the city of Montreal, they had been collecting samples for us from the beginning of, from the end of February. So we had all these samples, and we didn't know much about these viruses this virus at the beginning. We didn't know where it would be in the sample. We didn't know, we just basically took our samples and shoved them in our -80 freezer and had an archive from the beginning of the pandemic when it arrived in Montreal. But the good thing was this study gave us more confidence. It showed us that we have similar results. It also showed a bit of background that even Winnipeg, we were detecting the virus even in negative controls, because low levels of infections were visible in the samples. And it also showed what was really important is that the virus, there was a difference between when you spike a virus to measure it and then whether it's naturally present, there was a difference. And this is really related to the particulate phase. And this was where we have to have a lot of humility as researchers, because sometimes we have an idea of what is going to happen, but when we don't know, we really have to go through the testing to figure it out. And at first, that was one of the things that I had thought, and that a lot of us thought, that'd be harder to look at the particulate phase, and that we would focus on the water, the aqueous phase. That turned out not to be true. So it was really the particulate phase that was important. And so it's really good. But all of this happened much more quickly because of all of the groups working on this problem simultaneously. So this is how we've, in collaboration with Dominic's group at McGill, Dominic Frigon's group at McGill, we came up with a method that we would then use on the entire archive history from the beginning of the pandemic. So we have our wastewater samples. We have a lot of quality assurance, quality control, spikes, but the concentration method is what's important. So we basically separate the sample into the solids and then a supernatant, and then we concentrate it and we put it together for RNA extraction and then use PCR. So thankfully there were other people kind of helping us out getting this off the ground so that we could then apply this method to Montreal's wastewater. So Dominic had already mentioned how Montreal is set up for its its sewers. So on the north side of Montreal, and actually part of the West Island from the southern part, comes to this northern interceptor sewer. And then there's a southern interceptor. And so what we get coming into the city of Montreal has wastewater samples from two very different populations and with different characteristics. So we were able to monitor both. But very early on, we saw that the signal was much stronger on the northern interceptor sewer, and far more of the vulnerable populations are connected to the northern interceptor. So we focused a bit more of our efforts on that interceptor sewer. So these are the results that we have, and it's, I'd like to first say that it's uncorrected. This is really the as is, because when it comes to wastewater monitoring, the signal of the virus in the water can be also influenced not only by the excretion patterns of the population. There are other processes, and a lot of the sewer systems in Montreal are combined. There are sectors that are combined sewers, which means stormwater gets mixed in. Some are separated, so it's like only the sanitary sewer. So we have a mix of what's going on within the system. And so the signal can be diluted partly by stormwater or snowmelt. And so eventually we're doing research right now also to figure out the best way to correct for these other inputs into the sewer systems. But this is really the data as they are. And so we know at the very beginning of March, I personally knew people who were excreting into the sewer shed at this time, but it took a while for us to see a signal. But very early on, we saw the rise in the signal before the data reporting. Now, I'd like to say, especially given the importance of public health data, that what is reported publicly is a bit delayed compared to perhaps what is actually known by public health teams that are working. So this is really a signal that is from what's publicly reported. So it's possible that this red line that's a bit delayed compared to our SARS virus could be shifted a little bit forward to match up with what we see with the SARS, the virus in the wastewater. But what we did see is in the early spring, we saw a very rapid rise in the virus concentrations. And at that time, it was really when public health was also ramping up their testing for clinical testing. And not everyone, or very early on, had access to clinical tests. It was more focused on travelers and such. But what we see is that very rapidly in the sewage, we had a very strong increase in the early spring. That wasn't repeated until quite late in December. And what we did see we had a very important rise in number of cases in December, right before January. And that was when we finally saw the concentrations in the wastewater actually surpass what we had seen in the spring. It's a bit noisy data. We have data points like here, which was a sample that strangely had a pH of 1. So I think it had been altered at the plant, but we still have to go through this data cleaning process or normalization. But this is the data. These are the data as they are. And we do see that that important rise in the spring, and reassuring that in the summer it really was low, with a few exceptions, but we had very, very low concentrations, many below detection limits actually in the summer. And this is for the other interceptor, the sewer, and it did rise also at the end of December, but we haven't gone back through the whole archive yet, just because it hasn't been as important as the northern interceptor. And here it's related to the St. Lawrence. So like one of the questions is, and it's important to remember that although we're measuring this in wastewater, it's not necessarily a human health risk from wastewater at all. And there's no evidence of transmission through this route, but there was certainly an interest in what would we measure in the St. Lawrence. So this was a project that was led by François Guillemette from UQTR with the Lampsilis boat. And so one of my students went out on the boat, and we had collaboration with Lily Pang. We measured 7 enteric viruses, because it's not the only virus, SARS is not the only virus of interest, but we did measure SARS in the St. Lawrence after Montreal. But let's remember that even in the summertime, that those concentrations, even in the effluent coming into the wastewater treatment plant, were close to non-detect at that point. So what we saw was, we saw lots of other viruses, especially just immediately downstream of Montreal, and a few other locations. But what was really important was that there was no coronavirus. So these are the viruses that were measured, but no coronaviruses at all were measured in the St. Lawrence River downstream of Montreal. So that would suggest very low risk, even just on a numbers perspective, but there's no evidence at this point that that would be an important transmission route. So where do we go from here? I've talked about the monitoring of the interceptor sewers, but really where we're going from here on forward is looking at high priority sectors within the city as defined by public health. So sectors where there are a lot of nursing homes, a lot of like, for example, prisons, different sectors, industrial areas where there are a lot of high concentration of workers. So these are other areas that are of interest. We're also interested in sequencing the RNA for potential variants of concern. That's a new problem that cropped up at the end of December, and we have sent off samples for sequencing. And of course, continued monitoring of the time series for both of Montreal's interceptor sewers. So we do see the increase in when it's happening, and so it is an indication of what's happening globally within the city. And that's all I have. Thank you very much. These are the acknowledgements. Obviously, public health, City of Montreal, City has been phenomenal in working with us and getting us samples all through, right from the very beginning. Even though they themselves were having to protect themselves and figure out what to do at the plant, they were very collaborative in getting us the samples. The Fonds de Recherche du Québec, Trottier and Molson Foundations, Canadian Water Network, National Microbiology Lab, all the network of international researchers and the technical staff who make it all happen. Thank you.
Thank you very much, Professor Dorner, for sharing with us this really interesting data. Our third and final speaker this afternoon is Professor Robert Delatolla from the University of Ottawa. I actually had the pleasure of working very closely with Robert when he was a PhD student at McGill, where I was glad to co-supervise him with Professor Dimitrios Burke in the Department of Chemical Engineering. Now Robert, or Professor Delatolla, is the Associate Director and former Director of the Ottawa Carleton Institute for Environmental Engineering. His research is focused on biological wastewater treatment with a particular interest in the application, modification, and optimization of wastewater treatment technologies. So Professor Delatolla, please welcome and thank you again.
Thanks so much, Natalie. Pleasure to be here. I'm just going to try to share my screen. Okay, I hope you guys see the right screen at the moment. Well, thank you, Natalie. Thank you, Monica. Thank you to the Grace Institute for inviting me to talk today. And I'm very excited to talk to everybody about wastewater surveillance and variants of concerns in Ottawa. So we've been working on this study since April of last year. And this work has really been done at the University of Ottawa level. At the University of Ottawa in collaboration step by step with the Children's Hospital of Eastern Ontario Research Institute. But with that, the work has also seen a lot of collaborative partners. And there's been this, I think Sarah spoke to it and Dominic spoke to it too. It's been such a collaborative space. And we've been very, very fortunate to work with the City of Ottawa, Ottawa Public Health, Ottawa Hospital, the City of Hamilton, which unfortunately I don't think I have enough time to share data on Hamilton with you today, but a whole bunch of different partners in this space. We've also been lucky in Ontario that the province has recently started the Wastewater Surveillance Initiative, WSI. And that initiative is a $12.2 million grant that's funding a number of universities, 4 universities presently at this time, and up to 13 in the next few months to do this wastewater surveillance program across the province. The data I'll show to you guys today has been really in collaboration with a lot of other groups, with University of Waterloo, Windsor, Public Health Agency of Canada, and also I have to thank Dominic and Sarah. They've been a great resource to share information with and to exchange ideas and knowledge during this time. So with that, these are the actual people doing the work. So in my lab at this moment, these are the people who have done and produced the data I'm going to share with you today. And these guys work 6 days a week, many, many hours to do the work that you'll see today. So a little bit about the Ottawa case study. So we've been actually sampling wastewater in the city of Ottawa since April 8th. And what you see on the screen is the sewer shed map of the city of Ottawa. And that sewer shed collects involuntary contributions through the toilet of about 910,000 people in the city of Ottawa. And all of that sewer lines connect to one central treatment plant, and that's ROPEC, the Robert O. Picard Environmental Center. So 910,000 people collected involuntary contributions in one location at that central treatment plant. And you can see a picture of that treatment plant on the bottom right of your screen. So what do we do with that sample? Well, the first thing we did is when we started the study is we started to look at 6 different locations within that treatment plant. And we started to try to understand where is the best place to actually see that signal. And after about a month or two, we figured out it was in this obscure location, and Sarah touched on this about the particles attaching to solids, and it was within a primary clarifier. And a primary clarifier is a treatment unit within the wastewater treatment plant where the solids portion, all those little things that float in the wastewater, they end up in that location. So Dominic already spoke a little bit about how the viral particles are probably broken apart. So as we fecally shed, there's going to be particles entering into the sewer shed. And those particles, that's where we look for them as the primary clarifier. Once we have that sample, we process the sample, and we process it by centrifuging the sample to concentration step. Then we extract the genetic code, which is RNA in this case. Then we do a step called PCR, which amplifies that genetic code so we can read it. And if you follow that green arrow down towards the lower part of the screen, then what we end up doing in our lab is we normalize. And Sarah touched on this. We actually normalize for pepper-mild mottled virus. And I was following the chat, and I saw somebody mentioned it in the chat already that you can use this virus as a fecal marker, and that's exactly what we do. And I'll show you why we do that. So here's a little bit of data. So this is our data, actual data from the city of Ottawa from the months of April to June. And this was our very early days. And what you see on these graphs is you see a gray data set, which is the dashed line and then a shaded in area. This data set is the clinical data. It's the epidemiological data. It is the percent positivity. Now, it's not case numbers, but rather percent positivity. The reason it's percent positivity for this time frame of our data set is because percent positivity at that time was thought to be the better metric, clinical metric, to understand the prevalence of disease in Ottawa, because the number of tests were low. There wasn't a lot of, the testing hadn't wrapped up enough. So the number of positive tests per day, number of new daily cases was being dampened by the fact that there wasn't sufficient testing. So we have plotted our data against that percent positivity metric. And if you look at the data set, there's a blue line and there's an orange line. Those are two gene regions. It's the N1 and N2 gene region of the genetic code, that RNA of that virus that we find in wastewater. And you can see the first data set on the top graph. Now, if you follow that red arrow down, you will see that that orange line and that blue line have changed because we've normalized that data, and we normalized it for the pepper mild modeled virus. So we think that normalization by this factor, a ubiquitously shed fecal biomarker, allows us to see a true trend, or what we think is a more representative trend of what's happening really within the community. And there's a lot of reasons for that. You know, like a lot of people, the wastewater is by definition very variable. So there's diurnal effects. Day-to-day flows go up and down. What's in the wastewater, whatever you put down your sink, in your washing machine, that changes day-to-day too. Industrial activity changes day-to-day too, that feeds into our sewers. So all these things create a changing matrix. By having this biomarker and this normalization step, we think we're able to get a better representation of what's happening within the wastewater. And so here's the next set of data, the next time frame from June to August. And here you see three graphs. And the three graphs, the top graph is the wastewater data, those two gene regions of the genetic code. The second, the middle graph is actually your number of new daily cases reported in Ottawa. And the third graph is your hospitalization rates. So first thing to notice when you look at all three graphs is between June and July, everything's going really good. Like wastewater concentrations are low, new cases are low, clinical data, as good as it could be during a pandemic, and hospitalizations were low. So in Ottawa, it was a good period of time when things were very much under control. And then on July 17th, we noticed something. On July 17th, if you look at that top graph, we had a 400% increase in the concentration of the genetic material of COVID-2 responsible for COVID-19 in the wastewater. And that, we were able to see that and we were sampling every second day at that point. So at that time, we were able to see that sharp increase, and it really was the start of the second wave in Ottawa. We were able to see that 2 days before it was observed by Ottawa Public Health and clinical testing. And it was, we saw that increase in the wastewater 4 days before clinical hospitalization cases went up, 6 days before it peaked again, and 14 days before it ultimately peaked. So it kind of told us, hey, in the Canadian context, can this wastewater surveillance really be an early indicator, a smoke alarm for this, an uptick in the prevalence of this virus in our communities? And when we shared that data with Ottawa Public Health, they came back and said, awesome, you know what you need to do is you need to sample every day. So they asked us to start sampling the plant every single day. But in order to do, and they wanted us to report the data every day. But in order to do that, we had to change our methodology. So at that time, we had a method that took us 24 hours to get a result out. So we went back to the lab and we remodified our method of testing. And we created a method where we were able to actually observe the viral particles. And this relates again to something Sarah said about thinking about that genetic code attaching to the particles in the wastewater. We use that knowledge to modify our methodology and to simplify it really, and to be able to get data out within 8 hours. Since that time, since September, we have been testing 7 days a week in Ottawa, and we report our data in real time the same day to Ottawa Public Health 5 days a week. And this is how that data looks like. So you see, what you see here is the orange lines, and the orange lines are the 5-day moving point average, and the circles are the data points for that data set. That's the wastewater data. The teal, the shaded in teal data, that is your daily new cases. And you could see that there's sort of correlation when things go, when the cases go up, wastewater goes up, and they sort of follow each other. So that is the data that you see in Ottawa. But the real question at this point is, so what? You got two data sets. They follow each other. Dominic presented the fact that taking one sample in my lab costs $400. That data point costs $400. Taking us every single data point in teal costs, I don't even know, Dominic presented the numbers very well, but orders of magnitude higher. Okay, that's one point. But other than that, really, why are we doing this and what's the benefit? In order to talk about that, I wanted to show the data like this. So this is, again, the same data, and all we did was we overlaid some key events of what was happening in Ottawa at that time. And the first thing we learned, lessons learned, was in July, the wastewater data, when things are very low and quiet, can tell you ahead of time, possibly, that you're going to have an uptick and a resurgence in your community. So we know that. The other lessons learned was that we can see that the trend of the orange line moves upward when the case numbers move upward and downward when the case numbers move downward. And that's important because people fecally shed. What we're measuring are the sources everybody fecally shedding. So it really wasn't sure if we could measure that downward slope because whether you're asymptomatic or symptomatic, you fecally shed for a range of periods of time, depending on age and a number of different factors. So that's another key finding. But really, what was really important, what was really interesting is what happened between October 5th here and October 12th. And if you really focus on those two dashed lines, if you really focus on those those two dashed lines, look at the trend of the blue data sets going down. And look at the trend of the orange data sets going up. We diverged, completely separated. At a time right near Thanksgiving, right when the high, right when everything is kind of popping off, we completely, that time, the testing regimen in Ontario changed. And it became appointment-only testing, and the number of daily tests were lowered. And so at that time is when Ottawa Public Health started to lean a little bit on the wastewater data and use it to say, wastewater is independent of tests. It's involuntary contribution. And they started to lean, and actually we had a modified closure was implemented in Ottawa because of that. And you see something very similar between early December. You see the case numbers are plateauing in Ottawa, but the wastewater was going up. And at that time, there was sort of a debate in Ottawa between the province and the city. Should we shut down Ottawa, put it under lockdown like the rest of Ontario? Ontario, the case numbers were going up in Peel region, York region, Toronto, they were all going high. Should we shut down Ottawa? And it was the wastewater that was used as part of this conversation. And that's Doug Ford, Premier of Ontario, that's Mayor Watson of Ottawa. Dr. Vera Etches is tweeting about it. She is the head medical doctor in Ottawa. And Alex Montr is the CEO of one of the hospitals here in Ottawa. So that information directly translated at that time with us really knowing what was going to happen. We saw a so what moment. We saw those so what, like this can be used, and it can be used because it's a different metric. It has its own challenges, definitely, but it has different advantages than clinical testing. And that's something we've been able to witness here in Ottawa. Our data part of what we've been doing since September, since our arm was twisted, to start presenting this data 5 days a week in real time to the city, we've also been posting our data with the Ottawa Public Health. So Ottawa Public Health webpage describes the wastewater data, and it takes you to a link to the 613covid.ca website where our data is updated every day. And that data is being seen by somewhere around 1,000 to 2,000 people every single day are clicking on that data. It's many people from different countries are looking at that data. And we feel like this is a very important approach because it also helps the science. So it also helps us share our data with people all over the world who are trying to do this in their own countries and their own communities. So that's something that we're trying to promote with this work. So where are we going from here? Well, in terms of my lab, we've now expanded to 16 different sites. So because of the funding by the province of Ontario, we're now measuring and following the trend of COVID-19 and wastewater in vulnerable communities, in small communities and remote communities, and First Nation communities. We're also doing this work in correctional facilities. We're doing this work in neighborhoods in Ottawa that are particularly vulnerable. And with that work, we're developing a committee of vulnerable people to work with the data with us. And that's a voluntary committee to help us guide the research and the dissemination of that data. We're also working with shelters. So we have expanded this project across to 16 different sub-projects, if you will. But one other thing we're doing, and I'm over time, is we're also looking at variants of concern. So we've been able in Ottawa to modify the PCR method to look for the B117 variant. And we've been now testing the concentration, the wastewater, the variant within wastewaters in different communities. And there was one particular community that had a B117, a very unfortunate event in a long-term care facility. And we've been tracking with this assay that specific variant in that community. So I definitely went over, so I'll leave it there, but I just want to thank Natalie again, Monica again, the Brace Institute, and there's so many people that do this work. And thanks for the time today to share this information.
Thank you so much, Robert, for that very interesting presentation. Now time to open the virtual floor to the audience. If you have any questions for the speaker, please submit them in the chat. And if it is targeted to a specific speaker, please indicate so. And I'm going to read them out loud for our speakers. So I do have a few questions here already, and I'll start with the first one. This one is for Dominic. I think I did see that some of these questions were answered by other folks or even some of the speakers in the chat, but for everyone to benefit from the questions and answers, I'll read them out loud. So for Dominic, does the cost per test include labor and equipment? I've seen $250 to $1,200 per sample is the first question.
So it includes the materials and labor in the lab, does not include the depreciation of equipment, and it does not include also the sampling portion of it, which probably could easily double the cost that we have there. In terms of understanding the value addition though, if you're at 1% versus 2 or even 5% of the overall cost, it's probably the same argument. But there's some aspects that are not included there.
Thank you, Dominic. The second question is also aimed at you, but it's mentioned that it could also be for all. How effective is the testing for smaller populations?
I think probably Robert may have a bit more experience with this, as he's been sampling long-term care facilities. It's equally effective. We've done some work in mining camp settings, but the fact that you're much closer to the sample, you need to treat it differently. So. It's not so it's slightly different, but it is fairly effective. We actually could detect one case in the camp when we tested it, and they actually knew about it. It was a case in after the fact, so it was a healthy individual at that point, but that was still shedding. But you can still detect one case in the smaller number of people. Robert, do you have any comments there?
No, I think that's great, Dominic. Yeah, I totally agree. So whether small towns, I think Dominic presented and showed how many aerated lagoons you have in Quebec. And that's a very interesting issue because testing within an aerated lagoon might be difficult. But so we're looking at that scenario on how you would kind of adjust your sampling to be able to modify all of those kind of small communities we have across Canada that have these lagoon systems where it might be difficult to kind of do the same work. So we're addressing that, and we think we in the case study we're using in Castleman, we're able to track the virus there at that point too.
Thank you both. Sarah, did you want to add anything to that question with respect to testing smaller populations?
Yeah, so that's really where we're heading right now with we're starting to get samples. So what I've presented was where we had been, and where we're going is really deploying every day and collecting samples on a daily basis from smaller regions. And we're also testing out these different sampling techniques, like how does a passive sampler compare with a 24-hour composited sample? And what we really like is the city has also really brought in their perspective, because they have teams that this is what they do. So it's been really nice also to have the engagement from the city staff saying, well, I would like to do a composited sample on a 30-minute basis. So we've been able to bring in some of their suggestions. So we're going to be getting data going forward from these other sectors that should be interesting. And there's some parts of the city that are harder to get data for, and that's really where we're focusing on. So these workplaces, industrial areas and such, because people are more, a positive case is more likely to be associated with an address, a home address. And it might be more challenging to find these outbreaks in other settings. So that's really where we're moving going forward.
Thank you. For Dominic or Sarah, will Quebec be making data available through a public dashboard or a website?
I hope so. So I know Peter Van Hullem is very interested in getting that through the Central website. So we're certainly open to sharing. That's one of the nice things that's been happening with these collaborations, is that there's so much data sharing going on as well. There's just a lot of quality assurance, quality control to make sure that it's good data to share, but that's pretty much where we're at.
There's a question for all, and so whoever wants to take this one, what are the particular personal protective equipment that technicians taking samples need to be using for this type of project?
Similar to what you would for any other virus. Like one of the other reasons I showed some data from other viruses is the SARS virus is not the only one. And so if you're protecting yourself from the other viruses, which are also present in wastewater, that's that you can also protect yourself from the SARS virus.
Thank you, Sarah.
And maybe to add real quick, as I mentioned, the virus typically in wastewater is not infective anymore. I'm not aware during this epidemic now that there's a culture of wastewater that was at the end of the network there. So I think most of the time in the network, that would be in non-infective viral particles that you'd have there.
Thank you. Thanks. The next question is also an open question. Since it seems that the northern part of Montreal is crowded with a population that is potentially more vulnerable, more subject to poverty, and results used are based on that area, does it mean that the population is more exposed to the virus? Does it mean that the virus spreads more within that kind of population?
Yeah, these are good questions for epidemiologists as well, but we definitely see that that there are areas where, like for example, the difference between the northern interceptor and the southern, we really saw after the holiday time. Although there was pretty big spike in the northern interceptor. The southern decreased much more rapidly. I didn't show the most recent data, but definitely it took longer for the northern interceptor sewer to show that decrease. But we do know that, and there are data published per neighborhood. We know oftentimes where the pandemic originated in Montreal, and then so for example, Outremont, and then we saw other neighborhoods like Park Extension and Montréal Nord becoming more hard hit. But those, there are definite risk factors, but those are good questions for the public health epidemiology. And that's where it becomes really essential for those of us who are coming at this from the environmental engineering side to really have those close collaborations with the epidemiology folks.
Thanks, Sarah. A couple more questions from the audience. It will be interesting to see the effect of vaccinating on viral shedding into the wastewater. Is this work being planned?
So I think it's going to happen.
Yes.
We're going to keep going. Like I know in Ontario, we were funded until the end of August to do this work. And what's interesting is we're at certain long-term care facilities where all residents of long-term care facilities have been vaccinated. But what's very interesting is that you could still see people come in. You can have visitors, you can have workers, you can have cleanings, you can have all these situations. So we're working in some of those situations, and we definitely post-vaccination have seen viral signal related to certain circumstances in those facilities.
Yeah, and this is also where the sequencing and variants of concern is interesting. By collecting these samples, and even though the results don't come in very quickly, that there's an archive of samples, and certainly we will be looking at those things going forward.
Thank you both. So this question is addressed to Sarah and Dominic. If you could go to the government with a wish list, funding, resources, etc., what would it contain? What would you need to progress your research in the short term and do capacity building in the long term? Because we all know this is not the last pandemic.
Yeah, I think this is a great time to thank the FRQ and the Trottier and Molson foundations, because they came through. So now we actually are in a good situation. We have funding to do this work, and we're actually, we're going to be busy in the lab for the next few months. What'll be interesting will be what comes after. What have we learned from all of this? Because it's very intense in the short term. We've got the funding thanks to these groups, but it's really going to be like, okay, after all this is said and done, what do we learn? How can this be used in the future, and how can we integrate this technology into and make a closer connection to public health and public health decision making?
Absolutely.
So certainly one thing to add to that. So there's certainly specific areas that need further development. Sarah mentioned about variant sequencing. Right now we're running thin, trying to ramp up all the activities. But certainly sequencing and having maybe better funding to the sequencing labs. That we have samples that have been waiting for sequencing for 2 months now, and there's difficulties there to get the information that public health is actually asking us, so there's that. There's all this concept of integrating both the sequencing to the data, but also the modeling. There's a lot of development on the modeling side, and there's a lot of creativity that could be brought in trying to bring all these different elements of information into a large modeling concept. So there could be quite a bit of work there, assembling all these parts of the puzzle together.
Thank you. I'm seeing we're slowly running out of time here. I have time for maybe 1 or 2 more questions here, real quick, about a minute left. Second to last question, what device was used for passive sampling?
Sorry, I got distracted.
We're working with David McCarthy, who's come up with I don't know how, does it call it a poop torpedo? Is this torpedo that gets put into the sewers, and then it has an absorbent material that we can then extract the virus from.
Okay. Thanks, Sarah. And the last question that we have time for and I think this is a really important question as well, are the human resources needed for the sampling and analytical work sufficiently available, and can the training keep up?
So maybe I could speak to that. Yeah. So I think what you're seeing in Ontario, and I really hope you would see it in other provinces too, a little bit of a wink to Quebec here, that it would be really great when you have an effort at that level, at a province level, then you can be amazed at how quickly those resources could come online. There were 3 labs in Ontario that were doing this and that were giving data to public health. We're going to be 13 labs in a month. And that took about 2 months to build up. And then when you look at the capacity to sample, I think that you're going to be seeing a large percentage of the Ontario population being sampled for wastewater very, very soon. And a lot of remote and vulnerable communities, a lot of First Nation communities are coming online. So I think that if you have the right backing and you have the right infrastructure, in this space, like Dominic and Sarah said, there's so much sharing of information that I think, and there's so many people who want to get in this and have labs that can do this. If you just bring that infrastructure, it's amazing how fast these things could take off.
Thank you. Thank you, all 3 of you, for your time. This concludes our time today. I'd like to thank, again, all the 3 presenters for taking the time to share their important work with us. I think I speak for everyone when I say that we all learned something very new and important here today. I want to thank the Brace Center and TISED for hosting the seminar. And thank you to everyone who joined us. Have a great day and stay tuned for our next seminar.
Thank you.
Thank you.